In this video, temporary uterine artery ligation is demonstrated as an adjunct tool in conventional major laparoscopic surgery by using laparoscopic vascular clips. We start the surgery by identifying the ureter transperitoneally and follow its course into the pelvis. Cold scissors are used to incise a small hole superior to the ureter, and the scissors bluntly extend the small hole, allowing for insufflation to enter for areolar tissue to spread naturally. Atraumatic graspers help bluntly extend the incision as well. Once the space is open, the ureter is then easily identified. The graspers bluntly dissect around the ureter within the medial leaf of the broad ligament for continued dissection. After identification of the ureter, the uterine artery is easily identified just superior to the ureter. Maryland graspers are then used for further gentle blunt dissection around the uterine artery. The ureter is identified again while it vermiculates within the medial leaf of the broad ligament. Maryland graspers continue the blunt dissection to ensure when the uterine artery is clipped that there is an excellent seal and no other tissue is incorporated. Here the uterine artery is identified following its dissection. A 5 mm laparoscopic vascular clip is then introduced, ensuring that only the artery is incorporated into its jaws. The artery is then clipped and noted to be hemostatic without incorporating any other tissue. Attention is then drawn to the right side, in which the retroperitoneal dissection and ureterolysis is performed in a similar fashion. As you will note, primarily blunt dissection with atraumatic graspers are used following the initial sharp incision with cold scissors. Here we have an excellent view of the uterine artery and the ureter, medial and inferior to it. Maryland graspers are again used for further dissection and isolation of the uterine artery. Once again, the 5 mm vascular clip is introduced and secured after ensuring only the vessel is incorporated into the jaws. Here's a view of the clipped vessel. Following the primary procedure, attention is then drawn back to the vascular clip's removal. A laparoscopic needle holder is introduced and grabs the clips, and only the clip. It is important to make sure the clip is grasped in this orientation of the needle holder, as it pulls off the vessel easier. Additionally, gentle tension is important, as an aggressive pull will most certainly compromise the vessel. In the removal of both clips, scant bleeding is noted, likely from superficial abrasions. A Raytech is an excellent tool to use to apply pressure for additional hemostasis. After a few minutes of pressure, the areas are checked again and at a lower pressure to ensure complete hemostasis. Here we demonstrate another case where uterine artery clipping was helpful from an anterior approach given an enlarged uterus filled the posterior cul-de-sac. A bladder flap was created using cold laparoscopic scissors, and dissection to the uterine arteries was performed using blunt dissection with atraumatic graspers. The right uterine artery was identified first. Blunt dissection was continued until the left uterine artery on the opposing side was also visualized. The right uterine artery was mindfully bluntly dissected inferiorly to allow for optimal clip placement. This dissection can be performed with a curved bipolar device like we have done here or with Maryland graspers. The 5 mm vascular clip is then introduced and applied to the artery. Here we place 2 clips on the vessel as an additional insurance policy for hemostasis. A similar application was performed on the left side. Blanching was noted of the uterus thereafter. It is good to know that one can use vascular clips such as these, or bulldog clamps, or even suture ligation for the purpose of hemostasis in myomectomies. Removal of the clips was performed in the same fashion as the first case, ensuring that gentle traction is applied to avoid laceration of the artery, including microvascular tears. All surgical sites were hemostatic following removal.